Okay, so is my screen visible? Is it visible?
Yes, ma'am.
Yes, ma'am.
Oh, fine. So we are starting with the another obstructive condition that is called as asthma. Now, asthma actually is characterized by attacks of wheezing, breathlessness due to narrowing of the intrapulmonary airways. So इसमें क्या होता है जो responsiveness है airways की that is increased. So whenever the patient comes in contact with any of those allergens, the attack of wheezing and breathlessness starts and the narrowing of the intrapulmonary airways happens. Severity of the narrowing varies with short periods and is reversible either spontaneously or as a result of treatment. This was one of the important difference which I told you when I started up with obstructive diseases that COPD is an irreversible condition. Even if you give the medication, COPD won't be reversed back, but asthma can be reversed back with the conditions. So there is increase in responsiveness of the airways, trachea and bronchi to various stimuli. Now these stimuli can be different in different individuals. In some people it is the dust, in other people it is the pollen grains. So there are different, in some people it is the smoke. So the stimuli can be different. Some people asthma is triggered due to cold also. But the changes which occur, they cause the airway obstruction. And airway obstruction, when it happens, it includes hypertrophy and hyperplasia of the smooth muscles. So whatever smooth muscles are there, both the things will happen there. Hypertrophy will be happening and hyperplasia will be happening as well. The thickening of the epithelial basement membrane of the airways will happen. There will be edema and the eosinophilic infiltration of the bronchial wall and hypertrophy of the mucus gland. So all these pathological changes we will be able to see in case of asthma. Now, asthma can be of two types. It can be extrinsic asthma or it can be intrinsic asthma. Extrinsic asthma is one in which you will see that younger population is affected mainly and there's a positive family history. Means different generations of people must be having in the family the problem. Then it is related to some specific antigen and these attacks are intermittent in nature, but these are acute attacks and they are self-limiting. The patient will be healing to some extent by themselves as well. Whereas in intrinsic asthma, immunoglobulin E production is not demonstrated. In extrinsic, excessive immunoglobulin E response is there to the allergen. Intrinsic asthma is more common in adults over 35 years of age. There is no history of family history. Then the attacks are more related to that of with the infection and exercise. And the attacks are more severe in nature, and these are the persistent attacks. So these are basically the differences between extrinsic and intrinsic asthma. Now, whatever it may be, the airways they have a dynamic structure. So when they dilate, large amount of air is need to be moved out during expiration, and when they constrict, these need to be protected during exposure to irritant gases. What happens is that ability of the airway to alter their diameter in response to both internal and external stimuli is the airway reactivity. And as I said that there is increased responsiveness in asthmatics. So what happens is this ability of altering the diameter in response to external and internal stimuli, this airway reactivity, this is increased in asthmatics. And so they develop more intense bronchoconstriction. Mainly, there are three pathological changes in these patients: spasm of the smooth muscles, edema of the mucous membrane, and excessive mucus production. Bronchial walls जो हैं, they will be filled with eosinophils and thickening of the epithelial basement membrane will happen. Attack अगर persistent रहा, long standing changes होंगे, there will be hypertrophy of the smooth muscles. Increased number of goblet cells and mucous glands will be there. There will be over distension of the alveoli, and ultimately it will lead to air trapping. So ultimately, again, the patient is not able to eliminate the air out, and obstructive expiratory phase is affected. Now, allergic reactions can lead to the triggering of this bronchoconstriction. So whenever the antigen, which is the allergen, when it binds to immunoglobulin E, on the mast cell, This binding releases the mediator which act as the receptor site on the smooth muscle cell. And this will cause a change in intracellular cyclic AMP levels, resulting in smooth muscle contraction. So these antigen antibody reaction in the parts of bodies will happen, and if the patient has a previous exposure of antigen, it will lead to even greater bronchoconstriction. So here I have tried to show that what are the various aspects of the tracheobronchial tree, and like when we are saying the bronchial smooth muscles, these are the bronchial smooth muscles which get affected. Okay, these are the capillary beds. The alveoli, when air trapping happens, this happens there. Now, pathogenesis may we need the allergen is one of the most common things which will be there. It can be because of exercise or infection in adults. Then occupational stress or environmental stress can be there. Even pharmacological and emotional stress can lead to asthma. So, if we talk of the pathophysiology, there will be obstruction. It will be either episodic, as it's seen in young population, or it can be continuous. FEV1 and FEV1 by FVC, the ratio will be reduced less than 70%, indicating obstruction. So, whenever the spirometry is done, you can grade the severity according to the FEV1 by FVC. If it is reduced, this indicates that there is obstructive condition and the severity can be graded with the help of FEV1. Closing volumes will be abnormal, then vital capacity will be reduced. Residual volume, because of air trapping, the residual volume will increase. So, if how you will detect that there is asthma, whenever a patient comes for spirometry, आप spirometry कराइए, उसके बाद patient को bronchodilator administer करिए और उसके 2 घंटे बाद फिर से spirometry कराइए. So, improvement in 15% or more in FEV1 is considered as reversibility of obstruction. So, the patient will improvise the values of FEV1 by at least 15%. And in these patients, even the minute ventilation is increased. Now, how we can differentially diagnose between COPD and asthma? COPD is onset in midlife. It is never found in early life or in children. Asthma is early onset in life. Symptoms they in COPD they are progressive in symptoms, and in asthma symptoms depend on the allergen exposure, so they vary from day to day. Smoking is a very common cause of COPD. Okay, but in asthma, it can be because of allergy or rhinitis. Eczema can be present. They can be because of infection, or it can be because of exposure to any of those allergens. In COPD, they prominently there will be dyspnea during exercise. In asthma, there will be different symptoms. They can be allergy, they can be rhinitis, there will be excessive wheezing. COPD is irreversible airflow limitation, and asthma is a reversible airflow limitation. And in asthma, family history is at times present. Fine. So this was about the asthma. Now, if I talk about the rehabilitation aspect, prior to that, we need to assess the patient. So here, when we need to assess the patients with asthma, it is important that family history plays a very important role. The role of allergen is very important. If the patient is aware of that, how they are getting exposed to the allergen, when they are getting the symptoms, sometimes the patient is aware that whenever they get exposure to the dust or whenever they get exposure to the pollen grain, then it helps. But many a times the patient are unaware. So if you will go for the spirometry and the reversibility testing, then it will clearly identify that whether it is some other obstructive condition or whether it is asthma. In next class, we will be dealing with the assessment and rehabilitation of the asthma and other obstructive conditions.